Welcome everyone. We're going to start in a few minutes here, a few seconds actually, just waiting for everyone to join on. I'm seeing the number of participants go up exponentially, which is fabulous. Okay, welcome everyone to our virtual Global Health Forum, Racism and Global Health. How did we get here and where do we go now? My name is Parmi Suchdev. I'm a professor in the departments of Global Health and Pediatrics here at Emory and Associate Director of the Emory Global Health Institute. For those of you not familiar with the Global Health Institute, our goal is to advance global health across disciplines through collaborative, innovative, and impactful discovery, scholarship, and service. We host these regular global health forum series to disseminate timely topics in global health. And I cannot think of a more important and timely topic that we are here to discuss today. We are pleased to have with us an amazing panel of Emory faculty, scholars, and leaders to guide us on our journey today. Before we begin, we want to acknowledge and pay tribute to two remarkable civil rights leaders who we recently lost. Both dedicated their lives to social justice issues and were awarded the Presidential Medal of Freedom from President Obama. We're here today to talk about racism and global health. In the words of Camara Jones, racism is a system of structuring opportunity and assigning value based on the social interpretation of how one looks that unfairly disadvantages individuals and unfairly advantages other individuals and communities and saps the strength of the whole society through the waste of human resources. Global health is, as defined by Jeff Copeland, the Vice President for Global Health here at Emory, is distinct from international health and public health, and it is more inclusive in that it has no geographical boundaries and really requires multidisciplinary, interdisciplinary work. And really the core values of global health are in health equity. So on first glance, these two issues might seem to not necessarily be connected, but really our goal today is to convince you all that racism is a critical global health issue that requires our immediate attention. So here's our plan for the webinar. I'll introduce each speaker and they'll give a short overview of the following topics. Following their presentations, we'll have a moderated discussion using the questions you all submitted when you registered for the webinar. We had nearly 500 people register, and so there are many, many questions, so we apologize in advance if you don't get to your question. You can also enter your questions as the presentations go through the chat feature, and we'll try to get to those if there's time. So to start off, we're going to have Dr. Charles Moore, who's professor in the Department of Otolaryngology at the Emory School of Medicine and director of the Urban Health Initiative. In addition to seeing patients and Chief of Otolaryngology at Grady, Dr. Moore serves as president of the Healing Community Center, a federally qualified community health center, and he'll be talking about racism and implicit bias in medicine. Next, we'll have Dr. Falguni Sheth, who's an associate professor in women's gender and sexuality studies in the Emory College. Her research is in the areas of continental and political philosophy, legal and critical race theory and philosophy of race, post-colonial theory, and subaltern gender studies. Next, we're going to have Dr. Dabney Evans, who's associate professor and co-director of graduate studies in the Hubert Department of Global Health at the Rollins School of Public Health here at Emory. She's a mixed methods researcher of issues affecting vulnerable populations at the intersection of public health and human rights. And she'll be talking about the call to anti-racism for global health professionals. And last but not least, we'll have Reverend Dr. Robert Franklin, who is the James T. and Berta R. Laney Chair in Moral Leadership at the Emory Candler School of Theology. He was the 10th president of Morehouse College. His work explores the concept of moral leadership in the 21st century in different cultures and contexts in the United States as well as around the world. So with that, I would like to invite Dr. Moore to start us off.
Thank you, Dr. Suchdev, for that introduction and for giving me the opportunity to be a part of this really phenomenal and timely panel. Racism and bias in medicine has unfortunately had a long history, and consequently there has been a legacy of distrust that continues even till today. I'd like to spend a few moments with you discussing some of those things, and one example of that that I'd like to mention is the Tuskegee syphilis study, which began in 1932. It's important to note that the actual name was the United States Public Health Service Syphilis Study at Tuskegee. The study initially involved 600 Black men, 399 who had syphilis. And the study was conducted without the benefit of patients' informed consent. And the study was initially planned and projected to last 6 months, but it actually went on for 40 years. And I'll repeat that, it went on for 40 years. The men were never given adequate treatment for their disease, even when penicillin became the drug of choice for syphilis in 1947. Another example is the Gila immortal cell line used in scientific research. It is the oldest and most commonly used human cell line. It was derived from cervical cancer cells taken on February 8th, 1951 from Henrietta Lacks, a 31-year-old African-American mother of 5 who died of cancer on October 4th, 1951. The cells were taken from Miss Lacks' cervical tumor without her knowledge or her consent, which was a common practice at that time. Now, given what I've stated about that part of medical history of racism, you know, we can look and try to explore where prejudice actually begins. And we're not born into prejudice, but we do learn it fairly early in life. Research has shown that approximately around the age of 3 months, infants begin to demonstrate a significant preference for faces, and this becomes cemented more and more over time. And this in turn has direct impact on how medicine was delivered in the past and is delivered today. Initially, the field of medicine was segregated. The vast majority of Black physicians in the United States were educated at either Meharry Medical College or Howard University School of Medicine, both historically Black institutions. Another example of the segregation is right here in Atlanta, where Grady Hospital was segregated. There was the white Grady and the colored Grady. And it was segregated to the point that there was even a demarcation in the tiles to let you know which section you were walking into. And this facility was known by most during that time as the Grady's, representing the separate but not necessarily so equal hospitals within one hospital. Now you'll see on this slide here, the Institute of Medicine report in 2002 that show that regardless of insurance, people of color and Blacks in particular are treated differently. They receive fewer procedures and poorer quality medical care in general than whites. And this difference exists for patients despite them having Medicare or patients at VA facilities where differences in economic status and insurance coverage really should not be an issue. So even after taking into account income, neighborhood, health insurance type comorbid illnesses, factors which I need to point out that are usually invoked to explain racial disparities, health outcomes among Blacks in particular were still worse than whites. Another study where patient actors were given a script, again as indicated on this slide, they found that their treatment plan differed based on gender, even though they all had the same script. And studies have consistently shown that race can impact how we hear patients, how we interpret their symptoms, and there can be an assumption that patients might be non-adherent to a particular treatment, so it's not offered to them. Additionally, people of color in particular have been shown to many times be given less pain medication because there's an assumption that they will be more likely to abuse it. And other studies have demonstrated a preference to treat, for example, for chest pain or in other thrombolytic agents based on race. This, in some people believe, is demonstrated in Serena Williams' postpartum complications and the issues she countered that they believe are attributed to her race. Now, it has also been shown, though, that Black patients are more likely to get preventive services when paired with a Black physician. Underrepresented minority providers are more likely to serve minority, poor, and Medicaid populations. And patients themselves often prefer race and language concordance as associated with improved satisfaction, adherence, and trust. Now, given what I've just stated, I would like to show you this letter in this next slide. As late as 1959, there's a letter from Emory Medical School to an applicant from admissions that states, I am sorry that I am not authorized to consider for admission someone from the Negro race. Now, we know that this was not the only medical school where this occurred, but it wasn't necessarily put in writing. But you need to think about how many other schools had this policy, and knowing that people of color tend to provide care for more minority, poor and vulnerable populations, then policies like this had a tremendous impact. There is a systemic disproportionate burden that African Americans and other minority populations have on common preventable diseases, conditions that we all should not have to live with disproportionate impact. And the current pandemic has highlighted this fact. Next slide, please. This slide, you see that there are wide disparities based by race, most dramatically for Black and Indigenous Americans. What's important to note is that depending on the community, this may be due to numerous reinforcing factors related to such things as higher likelihood of contracting the virus because of workplace exposures, inability to work from home or have access to sick days, may also be from poor health outcomes after acquiring COVID-19, resulting from less access to testing, higher prevalence of underlying health conditions like diabetes, hypertension, and also from receiving delayed or poor medical care because they lack health insurance. So the racial disparities in COVID-19 mortality due to these factors are, in my opinion, really the result of systemic racism. And it's important to note that we don't know yet what the long-term effects of being infected with coronavirus will be, and we anticipate that there will be a disproportionate effects on people of color. Next slide, please. To really combat these disparities, we have to explicitly acknowledge that race and racism factor into healthcare. We have to live up to the legacy of Congressman John Lewis and Reverend C.T. Vivian, work diligently to reshape the way medicine is practiced and right the wrongs to truly have justice in all areas for all. And as a personal note of reflection, we truly lost a giant in Congressman John Lewis. When I was in the process of transitioning the health center that I started to become a federally qualified healthcare center, very few people would listen to me about it, but he took the time to not only listen, but write a letter of support and then come to celebrate with us when we obtained that designation. So not only was he a giant in so many ways, but he's a decent, kind person. Thank you for your time.
Thank you, Charles, for that sobering overview of where we're at. And so next, I'd like to call Dr. Sheth to come and really start giving us an overview of how did we get here. So, Falguni. Falguni, you're on mute, sorry. Sorry, still on mute. Britton, do you mind unmuting her? I don't have that ability from my system.
I continue to be muted. I'm hoping, I keep hitting unmute and then it says the host is muting me, so my apologies. Can you hear me now?
Yes.
Okay, thanks. I'm okay. So unfortunately, I've lost a little bit of time, so I'm just going to keep moving. One of the things I just wanted to pick up on, part of the story that Dr. Moore told about the Tuskegee Institute and the syphilis experiment, which was an outgrowth of this thing called public health. And I think, you know, one of the reasons that we have such outrage at this particular moment is because we tend to think of health as a kind of human right, that we tend to think of it as something that everyone should be able to be protected in. And I want to kind of go back to this story because in a sense, this is a story that emerges out of, if you will, liberalism and liberal values. And in particular, we have a story about rights, and public health as a notion emerges from that space. I don't think we would have it unless we had this idea of having a kind of global, universal system of rights. But the fact is, well, I won't say fact, but I think it's important to consider that these kinds of moments of crises are actually not accidents, that they actually go hand in hand with the story of liberalism, from, you know, the moment of kind of settler colonialism in this country onwards, that it's not an accident that we have a kind of constitution that emerges from political philosophers' writings, John Locke on the Second Treatise, at the same time that he is the administrative secretary for Lord Ashbury, who was the proprietor of the colony of Carolina, which was actually also in charge of engaging in the genocide of Indians at the time to clear land for settlers. That these are, I could tell you many other stories like this, but these stories unfortunately go hand in hand. And so I think we have to kind of think about not these particular events as accidents, but actually to think about how we need to stop hiding behind the story of rights and liberalism, to kind of think about how it is that in fact the language of rights is often deployed as a mechanism of security to protect those who are often in power. And so, you know, just a certain kind of example to that effect, the Universal Declaration of Human Rights, the United Nations, and also the World Health Organization all emerged in the aftermath of the Second World War, as the empire, as it were, was supposedly collapsing. And I think, again, it's not an accident that this is a kind of language that insists that we have to kind of attend to the rights of denizens around the world, at the same time that actually the conditions for African Americans in this country and also indigenous populations, Native Americans, was incredibly bleak, brutal, inhumane, that those two things actually exist side by side. So that when we think about what it is that's going on, as Dr. Moore's kind of talked to us about a little bit, I think it's important to remember that this is not something that's occurred on the spur of the moment. It's actually part of a long history of arranging our affairs, if you will, US affairs among other European affairs as well, in such a way that it privileges those who already have access to money and power. And so even though the WHO ostensibly was formed to bring first world technologies and sciences to the so-called third world to help them get up to snuff, one of the things that we're noticing, especially in this particular moment, is that there are many of the Asian countries who have figured out how to deal with COVID in a way that's very effective. And aside from the current administration, I think we have to kind of think about why that is. And part of that is because it's not just about science and medicine, but it's how we organize our affairs. That we organize our affairs so that we don't actually have things like social safety nets, that we don't have, we have a healthcare system that's predicated on a health insurance exchange, that's predicated on a minimal safety net, and that we're making policies like mask policies, which actually are enforced much more disproportionately against vulnerable populations. So African Americans who don't wear masks, and in fact, working class African-American populations and Latinos are much more likely to be harassed and brutalized when they don't wear masks, regardless of the fact that they're actually much more vulnerable to having to go outside to make, you know, to keep their income, to make a living, to ensure that they can actually keep a roof over their heads. And so that these two kind of phenomenon, both the absence of safety nets, the absence of organizing a world in which we have an ample supply of PPE, of respirators, of hospital beds, has been part of a long-term planning by a group of politicians and others who really thought that they didn't have a need for this kind of crisis planning. That's a pretty standard practice. And it happens because they're thinking that they can always have access regardless of certain kinds of crisis planning. So I think we need to kind of really become aware of the ways in which the aftermath of both empire and colonialism are affecting and really bringing, refreshing attention to a certain kind of systemic inequality that has been there for a very long time. So I'm going to stop there. I'm not sure how long I went, but.
That was perfect. Thank you so much, Fulgani. That was, you know, a really helpful overview on where we're at, and really how a lot of this is not, oppression is not accidental. So thank you. So now we're going to go to kind of the last two speakers who are going to really talk about, you know, where do we go? How do we take this information we've heard about where we're at, and what are some things we can do? And so I'd like to turn it over to Dr. Evans to talk about the call to anti-racism for global health professionals. Thank you.
Thanks so much, Dr. Suchdev, and thanks to Dr. Moore and Dr. Schatz for setting the stage for us. I think our audience will appreciate that talking about racism and global health in 5-minute segments is a really impossible task. So appreciate your patience and willingness as we speed through and try to think about where we've come from and where we're going to. So what I want to do is try and make this a little bit more personal, and I really want to speak to you all as individuals, global health professionals, and talk about the call and an invitation to anti-racism for each of us. So next slide, please. So I'd like to ask you to engage in a thought exercise with me. And if you have a pen and paper nearby, feel free to grab it. If you don't, that's okay. You can just sort of think quietly. But I want us to take the next 30 seconds or so to think about this question. So the question is, when did you remember first becoming aware of race? We'll just take about 30 seconds. So let me layer on to this question with another question, which is, how did you learn about race? So we'll take about another 30 seconds. And how you learned about race might come from that first experience, but think back and try and remember, how did you learn or how were you taught about race? And we'll just layer on one more piece of this question. What did you learn about race, your own or others, from this experience? So just 30 more seconds to think about what you think this exercise was about. And what I'm referring to is your first experience, not this exercise itself. So unfortunately, we don't have time in our brief time together to be able to debrief this with all 274 of you, but I hope that each of you will take time after this experience to reflect on this question. And part of why I wanted to ask this question is to begin to think about how this experience differs for people based on their racial identity. So for those of us that identify as white, I can share this exercise was developed by a couple of amazing organizers from here in Atlanta, Sharice and Skylar Jackson. and it's routinely used by an organization called SURGE, which is Showing Up for Racial Justice. And when this exercise is done, what we usually see is that people that identify as Black or people of color typically have a racial awakening or their first memory of race at a much earlier age than people that identify as white. And many of us are also familiar with the idea of the talk, that is the talk that Black parents may have with Black children about the ways in which they need to take care of their safety and security because of their racial identity. Whereas many of us who identify as white may never have actually had an explicit conversation about what it means to be a white person, and particularly the unearned privileges that we have because of our whiteness. So I just invite you after this talk today to consider this exercise, think about it more deeply for yourself, and then perhaps share with others and have conversations with others about it. I wanted to do this exercise because I really wanted to make this personal and to raise this idea about conversations. So we oftentimes do not have conversations about race. We typically have conversations about race when we're in a crisis. And I would say that we are in a crisis at this moment in this country, and a lot of important and long overdue conversations are happening, and we need those conversations. We also need anti-racist work. And I don't have time to fully go into this, but I would just share a couple of takeaways from my experience, which is that anti-racism work is urgently needed. People are literally losing their lives every day because of racism. And those come in the forms of everything from police brutality, as we've seen in the cases of George Floyd and so many others, but also in more hidden ways through racial health disparities. Anti-racist work is a long process, and it is both personal and structural. And what I hope to do in the next couple of slides is just to talk about what that means for people who are working in the field of global health. And for us to take up the charge of Ibram X. Kendi, who wrote this text, How to Be an Anti-Racist, to consistently identify and describe racism so that we can be more effective in dismantling it. Next slide. So I mentioned that anti-racist work is both personal and professional. So I want to take a few moments here to talk about some personal work and really share with you some opportunities to do that kind of personal work. So for those of us that are here in Atlanta, there are a lot of really active organizations, but even those for who are not in Atlanta, the resources that I'm mentioning here because of the COVID pandemic are going virtual, and so they're equally available to you. So I'll just mention them quickly. The first I mentioned already, Showing Up for Racial Justice, which is actually a national organization, but which has local chapters and which routinely offers 3-hour workshops on exploring power and privilege. And these are specifically focused on non-Black people so that they can really work to explore the privilege that they have because of their white identity. I also would point out the Racial Healing Handbook by Dr. Annalise Singh, who is actually based at the University of Georgia. And there is an independent feminist bookstore here in Atlanta called Karis Books that is hosting an upcoming book circle using this textbook, which is really about personal exploration. And then many of you will be familiar with the text I just mentioned, How to Be an Anti-Racist by Ibram X. Kendi. There's a local yoga studio here in Atlanta that will be offering a virtual series using that text, and I've listed the website here. Within the personal work, there's a lot of work to be done. But the main takeaway that I would say is that it really is about following, and what I mean by following Black-led organizations and other Indigenous and people of color-led organizations is literally following, right? People of color know what they need, and they know the support and the change that they want. And we need to listen to that, and we need to follow their direction. We need to support them by following them, and also by supporting them through divesting our own resources, energy, and time into those organizations. And the most important takeaway I would share about this personal work piece, and this really comes from Rachel Cargill, who's a leader in this space, is that doing this personal work is not self-help for white people. The goal always has to be about centering the experiences, lives, and the liberation of Black, Indigenous, and people of color. Next slide. So shifting to the disciplinary work and the professional work. For those of us that work in the field of global health, we think we're the good guys, right? We're the good ones. But I want to share this quote with you from an Indigenous activist and scholar, Lila Watson. who says, if you've come here to help me, you're wasting your time. But if you've come because your liberation is bound up with mine, then let us work together. And when I saw the quote from Dr. Kamara Jones that was shared at the outset about all that is lost because of racism and racial discrimination, it very much resonates with this idea that we all lose out because of racism. And so there's an imperative for us to work for the liberation of Black and Indigenous and people of color, but also for our own liberation if you're a person that identifies as white. So thinking about global health and the history that we've heard just a little bit about, particularly in global health, we know that tropical medicine grew out of a history of colonization. And I would be really remiss if I didn't acknowledge, especially for those of us that are here in Atlanta, that most of us are sitting on stolen Muskogee land. So we need to consistently carry that with us whenever we think about our work and the places that we go to and work in. So tropical medicine eventually evolved into what we call international health, and we had those different definitions that come from Copeland et al. But recognizing that international health came out of this history of tropical medicine, grounded in colonialism, and that the philanthropic nature of it was really grounded in a sort of white saviorism. And so we find ourselves in the current moment of global health, which for Copeland et al. Is grounded in this idea of health equity. But if we really want to achieve health equity and collaboration and partnership with global partners, then we must address decolonization. We have to actively take that on, just as we take on anti-racism within our personal lives. Next slide. So some basic steps on the disciplinary level. Consider joining these two movements, the People's Health Movement and Doctors for Global Health. If you work in a global health organization or program and you're leading that organization, same advice as the last slide. Follow, support, and donate to Black, Indigenous, and people of color-led organizations, including in the Global South. And if you're asked to speak on a panel like this one, in lieu of a stipend, ask for a donation to those kinds of organizations. And then finally, and importantly, amplify and cite the work of other scholars and activists who are often left out of the narratives so that they get credit where credit is due. Next slide. Finally, just tying the movement and the things that are happening within the US to the global context. We lost two great leaders this weekend, as was mentioned at the outset. And what you see on the left here is a picture of Selma, Alabama, with John Lewis there in the foreground over 50 years ago. And then you see today and things that are happening in the streets, not only in the US, but across the world, that have to do with issues of justice, racial justice, ethnic justice, gender justice, and so many of these issues that are really tied together. So I'll just close with this quote from Reverend C.T. Vivian, who of course we also lost this past week, and the same quote that, that was shared at the outset about leadership and the struggles in which we choose. And I invite you to join me in an anti-racist struggle that also includes decolonization within the field of global health.
Thank you, Dabney. That was spectacular. A lot to think about, and a lot of concrete things that I hope will continue through the discussion. So last but not least, I'd like to ask Reverend Dr. Robert Franklin to talk a little bit about the role of academia in kind of reflecting on some of these things we've discussed today.
Thank you, Parmi, and I'd like to affirm the power of the presentations we've just heard for the benefit of those who have joined us late. Dr. Moore, Dr. Sheth have provided us with important mapping of the landscape, domestic and global, of the impact of unconscious and explicit racism on patient care, on the lives of the people whom we serve. And looking at the history in this nation, going back to the Tuskegee study and others. And then I'm so grateful for Professor Evans, your important diagnostic exercise, inviting all of us to think about our first encounters of race and difference. And so I really want to just kind of wrap this with a focus on the role of the Academy in addressing racism as a global health action. And in the spirit of the presentations that preceded, I also want to invite us to think about this moment in history, think about this day and this time, and how this nation is in flux. We seem to be evolving, and how people are in the streets now. Some of you viewing now have been a part of those movements for social change in the streets. Today, C.T. Vivian, the great pioneer in the civil rights movement, born in 1927 in Missouri, C.T. Vivian is lying in state downtown here in Atlanta, in the state capitol. And when I leave this conversation, I'll be headed there. We're preparing now and planning for John Lewis's funeral services. So there's so much now that gathers. It's a part of this moment. And I'm so grateful, Parmi and the Emory Global Health team, for this conversation, which is so timely. I also just note, because I'll bet there's some artists out there, the fact that in addition to the struggle and the activism, when I look at Black Lives Matter painted on the street in front of the White House and in front of other interesting and some ignoble locations around the country, that's art on the street proclaiming certain messages about health. And I wonder if we might do more along those lines to convey messages that currently are not meeting the masses' needs. And so I simply highlight these ideas. These are all pretty straightforward, how we can honor the struggle underway, sponsoring research into the presence and impact of bias in healthcare. These colleagues you've heard from today are already engaged in that work. I saw a terrific question from a wonderful colleague at the University of Chicago, Hoda. Thank you for the question you posed in the chat as we grapple with the deep roots of this monster of racism and unconscious bias. But universities need to step up now, and let's hold them accountable to invest more research dollars in to racism and its impact on the health of especially people living in poverty and people of color. Secondly, let's highlight and disseminate scholarship and fresh thinking about the history of racism and anti-racist ideas. A lot of faculty have already written and published in journals and texts, and still no one has heard about it. And I wonder if this might be a moment for responsible and courageous faculty and deans to say, you know, 3 years ago, there was an important bit of work done by these colleagues. It didn't get the attention it deserved. Let's recover, let's present. And so I'm hoping that those of you who are listening will think about the activism you can exercise in your institution and in your alma maters. Convening. We need to convene more conversations now. There's a reason why there are hundreds of people have gathered for this call. People are hungry for more direction, for intellectual capital. And I hope all of you will be sponsoring conversations of this kind and bring diverse people together, not just the sort of usual colleagues. And don't fall into the trap of groupthink, but bring some unlikely voices, grassroots voices, Native American voices, voices that aren't often invited to the conversation. Make those conversations more strategic and impactful. The university should leverage its brand name equity to act, but also to undertake advocacy for justice, equity, and change. Look at what happened just a couple of weeks ago. And the Trump administration was seeking to bar immigrant students from coming to the country this year during COVID. And Harvard and MIT and then Emory and others stepped up and said, no, not on our watch. And again, how can your institution, your healthcare practice, your university, your department leverage its brand name equity? So I invite you to think about that. And in that spirit, I just want to affirm people over the 30 years that I've been around Emory who have really taken risks and done important things along these lines. And I'm so pleased that Dr. Kamara Jones's name was mentioned. Her leadership in the American Public Health Association, sort of getting this theme of social determinants of health on a lot of radar screens that hadn't thought quite about these issues in that way. Jeff Copeland has been mentioned, and I've affirmed some of the important work that he's done. Dr. Fleta Mask Jackson at Emory, and also James Curran. But I also want to note Claire Stirk, the current president of Emory University and our beloved and outgoing president, has been an important public health voice over the years and during her time in office. So let's also celebrate the heroes and heroines who have stepped out and said, this is what is right and good to do. I want to just close. I'll reference a book in the next title, but you'll see this notion of transformed nonconformists. And as we invite you to be people who break the silence, who exercise courage and advocacy, Martin King said, this hour in history needs a dedicated circle of transformed nonconformists. That the saving our world from pending doom will come not from the actions of an adjusted majority, but from the creative maladjustment of a transformed minority. So think about that. That comes from one of his wonderful speeches titled Transformed Nonconformists. I think you'll find it interesting. And then finally, a terrific book I've been reading lately, actually given to me by my wife, Dr. Cheryl Franklin, who's also has a degree in public health, and said, you need to pay more attention to this. And Professor Matthew is a law professor at the University of Colorado, but a few years ago, she wrote this book, Just Medicine, A Cure for Racial Inequality in American Healthcare. And many of you who are experts in this area will know most or all of the contents, but it was exceedingly helpful for me as a layperson, but an interested layperson in public health dialogues and as a community leader. So this book just does a terrific job. And I'll just make one point. Toward the end, she calls attention to the impact of a whole body of failed civil rights law and policy, and the negative impact it's had on the health of people of color. And she affirms the importance of the Affordable Care Act and new measures, new policies that need to come forward to protect the people we love and we serve. So thank you all for your attention.
Fabulous. Thank you so much. That was a perfect recap of the conversation and a good segue into some of the discussion we'd like to open up now. So I'm seeing some questions come in. We reviewed some of the other questions. I guess I wanted to start off with a question to Dr. Moore, and others can chime in as well too. And the question is about kind of denying this issue of structural racism. And so the question is, I have a physician colleague from Chile who denies the existence of structural racism in the US. What advice can you give? So again, people outside looking in, it's not an issue. And what would you say?
So I think some of the things that I have talked about earlier in my presentation illustrate some of the structural racism issues, knowing that generally there's roughly about, I think, 6 to 8% of physicians that are and surgeons that are Black, and that the cost to go to college and medical school can be prohibitive, as well as the gatekeepers are numerous in terms of how people are able to access that. For example, the letter that I demonstrated, but also many universities and medical schools will use standardized tests as a point to decide whether or not someone even gets an interview. And has been shown in a number of studies that if you change the language but keep the content the same, that people of color, Blacks, Latinx scores will rise. White scores tend to decline, Asian stays the same. But there has not been any effort to make those changes that will allow more people to have access to care. I can also talk about my, my own personal experiences in seeing that, and with my family, that until certain physicians know, or providers know that I am a physician, I'm not offered certain things. And then my family will often bring me in, and then the conversation changes differently from similar situations, similar health issues, as someone else who actually refer them to that. So there are a number of things I hope that colleague was able to tune in today to get a sense of the number of structural issues that still exist and ways that we can potentially address them.
Thank you. I guess the next question, maybe to start off with Fulgani, but then others can chime in too, is this issue of, you talked a lot about oppression and how it can be non-accidental, but then how there's a lot of intersections between various types of oppression, whether that's race, whether that's gender, sexual orientation, class, religion. I've experienced some of those, more so than even my race as someone who wears a turban. So how do you call attention to these? Because it's so vast. How do you call attention to these collectively while not prioritizing one over the other? I think many of us struggle with that.
Yeah, I think it is important to what kind of practices and policies are leading to that kind of oppression. And so, for example, in my last book, one of the things that I talked about was the ways in which US law is used as what I call a technology, that it's used to basically group certain kinds of people in different kinds of groups as criminals. And we've been having this conversation quite intensively over the last 5 years with regard to African Americans and how they're vilified. But I think also US policy, we're seeing this now, the creation of certain kinds of offices and institutes like the Department of Homeland Security, which is now being used to police people on the street. So I'm not answering your question directly, but I think it's also important to kind of say what kinds of practices are leading to this kind of discrimination, are leading to this kind of harassment. So when you have a state that creates something like the Patriot Act and says, well, we need to go after terrorists, that kind of category, right? Unless we start looking at that category really critically and reflectively, it ends up being a kind of implicit endorsement to harass someone like you who wears turbans, right? Because the assumption is, well, terrorists look like certain kinds of people, and then that category gets extended. So, it's now being used to kind of, for a long time, it was being used to keep migrants from crossing the border. It was being used to deny refugee and asylum applications. And so, it's not glamorous. It's actually a little harder work, I think, also, but I think it's important to kind of say what kinds of laws and policies are being practiced that actually amplify the kind of harassment, intersectional harassment that people end up facing. So that even though when a certain law is kind of being directed at someone that you think you understand who the target is, that kind of law, especially when it appears neutral and it's really about bad people versus good people, that can be directed towards anybody who ends up not being considered part of the mainstream, right? Dominant population. So mostly white people, but all kinds of other kind of populations of color. And, and that's kind of what we're seeing now, especially with regard to refreshed attention with regard to African Americans. Does that answer?
Yeah, would anyone like to add anything?
I'm pleased that Professor Sheth emphasized this notion of intersectionality. And I think that's a powerful analytic tool. And thanks to bell hooks and the womanists and feminist scholars who brought that forward in the academy, at every point along the way, we have to kind of remind ourselves how does gender, how does sexual orientation, how does race and ethnicity, how does language, how does religion factor in, and the impact on differential populations, so that we don't get too narrowly dug in our analysis. So I appreciate intersectionality as liberating methodology.
Absolutely. I would just underscore that a little bit further. And for anyone that's not familiar with the work of Kimberly Crenshaw, I would refer you to her work, and really groundbreaking. She's a legal scholar and looking at a particular case, which is really, how the intersection of identities came to be, of a woman who was a Black woman who was experiencing discrimination on the job, and her exploration of filing a case as, yes, there were other Black people that worked at this workplace. Yes, there were other women that worked at this workplace, and how to figure out how to make that argument against an unjust policy where this person didn't both fit both of those identities, but the intersections were not addressed.
Davini, I wanted to ask you another question that was raised by a medical student at UIC, and so as someone who's leading curriculum design in a global health department within a school of public health, in terms of how do we introduce some of these topics of anti-colonialism into global health curriculum, and because and you mentioned this very clearly in your talk, because the way we're doing it now is not getting us there. And so how do we move that needle?
Well, I think that, we have a lot of challenges that we have to face. Traditionally, public health and global health as well has been very siloed into disease areas. And so we have a tendency, both as human beings, to sort of categorize things, but also within this discipline of public health and global health to fall into these disease silos. And what we see happening with the exploration of incorporating these issues of justice, racial justice in particular, and decolonization, particularly to global health, is we face this tension between, this is not something that you can have one lecture on, right? The sort of classic cultural humility or diversity thing. You can't have one diversity training and then everybody knows about it and the problem is solved. So you can't take a checkbook box approach. But the other danger is if you say, yes, this is a truly important topic and it will be woven throughout, sometimes that means that it can get lost, right, in the cross section there. So I can share what we're doing right now within global health and within the School of Public Health more broadly, is we're beginning to do an inventory of our courses and beginning to think about this and some of the things that I mentioned in my slide. So for example, if you're a person that teaches a course, look at your syllabus, look at your individual syllabus and ask yourself, how many people of color, how many people are authors from the global South for the readings that I'm assigning? Who are my guest lectures? What are the topics that we're talking about over the course of the semester? And for students in the class as well, and obviously there are power dynamics between instructors and students, but I think it's very fair for students to be able to question, where am I represented? Or where is this perspective or this voice represented? As instructors, we have the responsibility to ask that of ourselves when we're designing our syllabi. But if we don't do a good enough job, students can demand it. And in fact, I think that that's the equivalent of grassroots movements within schools of public health. So I welcome that kind of movement.
Absolutely. And just to add, I think, with this, the COVID pandemic, I think that the whole field of global health is going to be different as we know it. I think even the global north, the US, others aren't necessarily even going to have a seat at the table anymore, because we failed in many ways to address this. And so I think that power dynamic is going to change moving forward, and really gives an opportunity to rethink, how, especially with this traveling and these short-term trips to go help, as you said, do those make sense? So another question that, to Robert, I guess, in terms of, more what universities can do, I think you had mentioned some of these things, but a question that came up quite often is money, right? So where's the financial commitment and really a change in mission commitment by kind of the academy to really move the needle on some of these issues? Where does that come from?
Let me mention three items here. Number one, the importance of this idea sort of being in the air, in the culture of the institution. So early on at the beginning of an academic year, convening a town hall meeting or some kind of forum in which we articulate concerns, and hopefully, you've done homework, what shortcomings there are, or relative to other expenditures and budget lines, what's being devoted to this focus on, race difference, social determinants, however you choose to frame it in your context. So I really affirm the power of town hall meetings where everyone can have a voice. And that's part of what I love about this kind of a Zoom town hall. anyone can post a chat comment, presumably. And so we need to hear from the voices of the people in this democracy. Secondly, the importance of audits, of taking note of where monies are being spent. And sometimes that requires outsiders to come in and undertake a kind of campus climate or campus audit of expenditures in issues of reversing inequities, etc. So town halls, audits, and then ultimately the importance of leadership, the tone at the top, tone at the top. And as alumni, as students, as faculty and staff, we can hold our leaders accountable, challenge them. I think we learn from C.T. Vivian and John Lewis, we begin in a posture of negotiation, of respect. And if things don't go anywhere, then you turn up the valve, you turn up the dial in terms of activism and confront. So, and that was the genius of the civil rights movement, is this kind of two-pronged, alternating rhythm of confrontation and negotiation.
Thanks. Would anyone like to add? I mean, I think in my experience, I think we can also do it at any level. So it doesn't necessarily mean you have to go to your president or your CEO or your, you can start, with your college, you can start your department, you can start your organization, and there's something we can all do at any level, to start making some of these changes that we all desire.
One thing I would like to add is I'd love to see universities across the nation really become true anchor institutions where they provide economic opportunity for people in marginalized communities, that they are really positioned there so they can help individuals get additional training so that they're able to advance and have more economic improvement, which will impact everything that we've discussed today.
All right, so we're just at time. So I know there have been several other questions. One thing we've thought about too is this webinar will be recorded and it'll be posted online. And what we're also thinking as panelists is we're going to kind of compile some of the resources. There've been some really, really useful resources that each of our panelists has introduced and challenged us to look into. And so we'll compile those and share it with everyone who registered. We also wanted to make you all aware of this opportunity by the Urban Health Initiative, which is co-sponsoring this webinar here at Emory, about to submit some videos about issues of race and your own experiences with that, your own stories with this. And so you can submit your video to this link, and then these will be used as part of a project. I don't know if Charles is going to add anything to that opportunity.
This is a way to continue this conversation. So as Parmi has said, to share your voice and let others know about what you're thinking and potentially where we can go.
Thank you. And then just in closing, you'll also be getting an evaluation, and we encourage you to fill that out too. This ideas for future events and seminars to do, and we're also hoping this is just the beginning of some more in-depth conversations around this issue. I think the global health community has a lot of work to do, and it's hard to do in 5-minute segments and in a 1 hour webinar. So so stay tuned. I think we might have several smaller sessions where there might be required readings or kind of more homework and to really dive into these issues more. And we hope to work with others on putting those together. So feel free to reach out if you have ideas or would like to be engaged. And then like I mentioned, the recording of this will be available on the Emory Global Health Institute website shortly. And so I'd like to thank all our panelists. They're extremely busy people, and we're really taking on this incredible journey. And I know I've learned a lot, and I hope all of you have as well. So with that, thanks.